in the medical OPD for the intermittent loose motions associated with vague abdominal pain for the last 3 months. For the last 3 months, vague abdominal pain for the last 3 months. He noticed fresh blood in the stools accompanied with the painful defecation recently. And he admitted the significant loss of the weight. More than 10% of the loss occurs in 3 months. His paternal uncle died of the carcinoma of the colon 3 years back. Even there is a family history of some colonic disease. On examination, the temperature was 99 degrees Fahrenheit, which is low-grade fever, pulse 121 per minute. It is high-volume pulse. Anemia, because the patient was anemic. The blood pressure is also 114/76. And a tenderness is noted at the left iliac fossa. His investigations, which I have already mentioned previously, hemoglobin was lower down, MCV was lower down. Some of the liver functions were deranged, and the random blood sugar was low, and stool examination showed the increased quantity of the WBC, and the occult blood is also positive. This is scenario number 1, which I have discussed previously. Now, this condition, which is in front of you, has got a lot of differential diagnosis. The most important differential diagnosis and most important investigation is the lower GI endoscopy and histopathology. In the end, it turned out to be a case of the inflammatory bowel disease, which I will discuss and summarize for you. But the second scenario is this: a 60-year-old woman. She had got diarrhea for the past 3 months. She denies any nausea, any vomiting or fever. Her appetite is poor. She initially attributed to the diarrhea to the travel, because she has recently been traveled to some place in India, but her symptoms have not resolved over the several weeks. He traveled to Singapore prior to the onset of symptoms. Not India, Singapore. Now, there are 2 cases in front of you. One condition is progressive condition leading to the loss of the weight and the red flag signs, which I have told you previously. In the second scenario, there are no red flag signs are there. In her case, it is probably the lower bowel diarrhea. In the scenario 1, it is predominant large bowel diarrhea. Now, in this condition, scenario 2, the most important thing, because she has traveled to a place where she stayed in some hotel, etc., so probably she acquired some infection. And the infection is so much so that it lasted up to the 3 months of period. And because it is a lower GI, gastrointestinal tract, the commonest cause is Giardia lamblia. So stool DR was done in her case, and the trophocytes of the Giardia lamblia was found. This is the scenario number 2. Now, there is another story which is not written here, of the student of your batch, one batch senior to you. She was complaining of the diarrhea off and on, abdominal bloating, and symptom-free period for 3 to 4 days. And she was also losing some weight also, although not significant weight loss, but losing weight. Now this is the third story which I told you, and it is a true story, and she is senior to you. I don't want to name that student. All investigation has been done from head to foot with the examination, and no positive finding was found. This is scenario number 3, which is not written here. And this is the case in which when I examined her, only thing is there is slight tenderness in the parachoric gutters, in the lumbar area, in the left iliac fossa, in the right iliac fossa, in the left lumbar, in the right lumbar regions. There is slight tenderness. Now, the third case is most likely to be the irritable bowel syndrome, because there is no red flag sign in her case, and there is no infective element is found during investigations. So we will discuss to diagnose the patient's complaint. History has been taken, I said already, the physical examination should be done with lab studies, thorough examination should be done. And then the upper GI endoscopy in some cases and the lower GI endoscopy can be done with the biopsy histopathology. And the stool biochemistry can be done also. And how would you assess the illness severity, the length of the time since symptoms first appeared, impact of the diarrhea on the daily function, physical examinations, stool frequencies? All these cases, at the primary healthcare level, we give Salium, bismuth subsalicate or loperamide, which is available as Imodium capsule, codeine, etc., and Lomotil tablets, that is diphenhydramine, and with ORS, etc. And we usually tell these patients that take the light diet. This is the empirical therapy before we go for the vast clinical evaluation. Now this is how the patient say that the patient is in front of you. There is tenderness and I feel gas production, I feel bloating and other things. There are a lot of terminologies are related with the two hands placed on the anterior abdominal wall. Now the third case will be discussed, that is irritable bowel syndrome. According to the study of the Aga Khan University Hospital in 2007, it was done with the students. And there are about 600 students has been taken for the questionnaire. On the basis of the questionnaire, the selected patients are separated and they are examined accordingly. In that study in AQH, they said that more than 60% of the medical students are suffering from irritable bowel syndrome. It is a very common condition in young persons. But remember, they should not be associated with any red flag signs. Otherwise, it is not IBS. It is something else. Diagnostic criteria of IBS is manifold. There are two criteria which is accepted. One is called Rome 2 diagnostic criteria. It is European criteria, British criteria. And second one is the Manning's criteria. Now, Rome 2 diagnostic criteria with the British is the at least 12 weeks history, which need not to be consecutive. In the last 12 months of the abdominal discomfort or the pain that has two or more of the followings. It is relieved by the defecation, an onset associated with the change in the stool frequency. Previously it was 1 stool or 2 stool, now it is 4 and 5 stools. Onset associated with the change in the form of the stool. The stools are sausage shaped usually. Now they are not sausage shaped. They are broken in nature. Or something else, you can say. It is a dewy in appearance or something what we called as gober type of a thing. So this is called the Rome 2 diagnostic criteria. It is the British criteria or European criteria. The American the supportive symptoms with this is constipation predominant type, one or more of the bowel movements less than 3 times a week, hard or lumpy stools, staining during a bowel movement. This is constipation predominant type. There are two ends. The second one is the diarrhea predominant type. One or more of the following, that is more than 3 bowel movements per day, and the stools are loose, mushy or watery stools. And their urgency, and there is hardly any time to hold the stool, and there will be fecal incontinence. There is a history of fecal incontinence also. In general, the feeling of the incomplete evacuation and the passing mucus per rectum in some cases, not all, abdominal fullness, bloating or swelling. The second criteria which I follow is Manning's criteria. It is American criteria. They said that there are 3 or more features should have been present for at least 6 months. Minus red flag signs. Remember, minus red flag sign. If you find 3 or more of the lower down features, you can label the patient as IBS, Irritable Bowel Syndrome. Number 1, pain relieved by defecation. Number 2, pain associated with pain onset associated with more frequent stools. This is called tenesmus. Looser stools with pain onset. Vice versa. After there is a loose motion, the pain starts afterwards. And abdominal distension and gaseous formation, oblique. Mucus in the stool, but not in all cases. A feeling of incomplete evacuation after defecation, this is a very important point. The patient feels that he is not satisfied with his or her defecation. If the 3 or more features are present in young person specifically, and it lasts for at least 6 months, and all investigations are negative, it is the diagnosis of exclusion actually, then the patient should be labeled as Irritable Bowel Syndrome. It is one of the most difficult diseases to manage. Now, associated symptoms in people with IBS in the hospital OPD, 25% have depression, 25% have anxiety, and patients with the IBS symptoms who do not consult doctors, population surveys have identical psychological health to the general population. And these are important ones. Associated symptoms. And this is the sounds you are hearing are the break sounds. Stop here and see the third point. In one study, 70% of the women IBS sufferers have dyspareunia, painful coitus, painful intercourse. So, stressful life events are associated. Compared with the controlled, people with IBS are less well educated and have poorer general health. Women are more involved than the men, the ratio of 3:1. Now this is about the irritable bowel syndrome. The management is very difficult. I already said it that in these cases, the patient should be educated that the colonic mucosa is sensitive actually to the products, in the end products, because the all absorption occurs in the small intestine. The function of the colon is to absorb water. This is the main function or prime function of the colon. If there are some particles which are not absorbed and if they are touching it to the mucosa which is now sensitive, threshold levels are lower down in these cases. The patient feels pain and he will go to the latrine many times a day. And there are persons who have got relation with the food also. Some foods are absorbed and some foods are not absorbed properly. Nowadays, I have seen many cases of IBS who are exaggerated with mangoes because mangoes has, fibers, high fiber diet. And fibers, they are not absorbed. They are touching the colon and irritating the colon. First of all, you reassure the patient. Secondly, when patient becomes reassured that there is nothing problematical, then some anticholinergic drugs can be tried. There are many anticholinergics can be given, like for example the loperamide, like difenoxylate, like for example the belladonna compounds, hyoscine butyl bromide. The most successful drug in this condition is mebaverine. Mebaverine is the drug which we usually give to these patients who have got painful colon with diarrhea. And we restrict the diet in rather 3, they will take in 6 times, small amount of diet. The cold drinks for these people are poison. For everybody it is poison. Do not take any cold drinks because it will stimulate the gastrocolic reflex and gastrocolic reflex will initiate the problems. So mebaverine or deltapaverine and other second generation or third generation drugs are available. We also use one drug which is called the locally acting antibiotic, which is called rifaximin. In refractory cases, we use this drug, rifaximin. Rifaximin is used usually in hepatic encephalopathy because it is not absorbed. It cuts down the flora of the bacteria in the colon to reduce the nitrogenous products. We use rifaximin, which is available in, and we are using here in those cases which are refractory to the therapy. These patients are always relapsing, remitting, and they are not satisfied with the doctors. Remember, they have to be educated that they should manage themselves rather than go to the physician often. I have seen one case in which case he was diagnosed IBS in 1952. Now the age in his front of you, 1950 and 52, he has started these complaints, and the diagnosis was made at that time as IBS. Now in this age group again, he is coming with the symptoms of the Manning criteria of the Rome 2 criteria. I am managing this case by educating the patient and by giving mebaverine, sometimes rifaximin, sometimes I change these anticholinergics, patient become fine, and again constipated. So the fibers are given then afterwards to remove the constipation. Constipation alternating with the diarrhea. This is the problem in most of the cases. Now, second discussion is very important. That is the inflammatory bowel disease. This is inflammation of the colon. This is nothing which I am talking, but inflammation of the colon or inflammation of the small intestine. If there is inflammation of the colon only, it is colitis. And if it is inflammation of the small intestine, it is called enteritis. If there is inflammation of both of them, it is called gastroenteritis or gastroenterocolitis. Now, this disease has got two polar ends. One is known as ulcerative colitis. The other polar end is Crohn's disease. In between, there are many subdivisions are there. And it will be discussed in detail when you will be in the final year, if I will be alive at that time. Because this is my favorite topic, inflammatory bowel disease. So the inflammatory bowel disease, usually the portions involved, I already said, the large intestine is involved and the small intestine is involved. Part of the small intestine is involved. The disease is important, inflammatory bowel disease, because it will lead the complications. The most dreadful complication of this disease is carcinoma of the colon. So we have to treat these patients for life. Otherwise, they will develop carcinoma of the colon. The comparison has been done in this chart very nicely with the two polar ends of the disease, that is ulcerative colitis and Crohn's disease. That is, in ulcerative colitis, the depth of inflammation is only mucosal or submucosal, mostly mucosal or submucosal. But in Crohn's disease, the three layers of the intestine is involved. The mucosa is involved, the submucosa is involved, and the lower down serosa is involved. Transmural, whole of the wall of the intestine is involved. The pattern of the disease is contagious infection. It is symmetrical infection. No part of the colon is left. But in Crohn's disease, there is skipped areas. Some areas involved, some areas are not involved. Location on the ulcerative colitis is basically the rectum, anal canal, and the distal colon are mostly involved in this case. Crohn's disease is the multi-system disease, I will say. And the mouth to the anus may be involved. Rectal involvement is usual in 90% of cases with ulcerative colitis. Rectal involvement in the Crohn's disease is 50%. Ileal disease, which is called the backwash ileitis, is about 15 to 20% of patients receive this disease. You know, this is the distal ileum where the vitamin B12 is absorbed. Remember this point. These patients have got vitamin B12 deficiency afterwards. Ileum is always almost involved in Crohn's disease. Fistulas are rare. Perianal diseases are rare in ulcerative colitis, but it's very common in Crohn's disease. Crohn's disease is a granulomatous type of inflammation in 10 to 30% of cases, or rather more than that. There are no evidence of granulomas in ulcerative colitis. Overt bleeding is usual in ulcerative colitis. It is less common in Crohn's disease. Malnutrition is unlikely in ulcerative colitis. The patient will lose weight, but it will take a very long time. But in Crohn's disease, the malnutrition occurs very commonly because the small intestine is also involved with the colon. So there is significant weight loss. Cancer risk in the colorectal cancer or cholangiocarcinoma, if there is a primary sclerosing cholangitis is there is a risk in ulcerative colitis. There's more chances are there. But in Crohn's disease, the colorectal cancer and small bowel cancer, depending on the disease location, is there, but there are less chances. Very interesting thing is the tobacco use is protective in ulcerative colitis. It doesn't mean that those people who have got IBS, we say that use cigarette smoking now. It is a protective. It is written tobacco use, not cigarette. Tobacco means the other forms of the tobacco, not the cigarette form. But if it is used in the Crohn's disease, it will accelerate the condition. It is harmful. It can cause the colorectal cancer in these conditions. This is a very, very important chart in front of you. Now, this comparison is going on. I already said the rectum is involved in 90-95% of cases of ulcerative colitis. But in Crohn's disease, it is less than 50%. And any part of the gut is involved from mouth to the anal canal. And etiology unknown, there are many theories behind it. I don't want to discuss. Smoking is beneficial, already mentioned out. It is very harmful in Crohn's disease. Mucosal is immunological. It is autoimmune disease. Crohn's disease is autoimmune disease. In ulcerative colitis, weakened mucosal barrier is there while you go for the biopsy. And in Crohn's disease, the receptor specifically they picked out as TH receptor, which is present in Crohn's disease. And there is a defective mucosal metabolism of the bitrates. In cases of the Crohn's disease, there is no defective metabolism of bitrate, but the variant of the tuberculosis, because tuberculosis mimics this disease. Intestinal tuberculosis is very important differential diagnosis of the Crohn's disease. So as far as the etiology is concerned, the tuberculosis, I said, it is very important because colon is not involved usually by the by tuberculosis, but small intestines are involved. And in Mycobacterium para-avian tuberculosis, which is called Jones disease in cattle, is a variant of tuberculosis. Anyway, the Crohn's disease mimicking the tuberculosis of the intestine. Now, yeast, if you used mannose, yeast antigen antibody reaction will cause the exaggeration of the symptoms. In ulcerative colitis, the yeast will not do anything. There is a cure of the disease in ulcerative colitis. If the patient will follow properly, then he can be saved from the consequences of the complications. But in Crohn's disease, even after the management you are doing, the patient usually worsens in most of the cases. So in the ulcerative colitis, these sulfites reducing bacteria, they are found. And in Crohn's disease, the Listeria monocytogenes and Paromyxovirus and measles virus will worsen the condition. Chromosome 6 is involved in ulcerative colitis. Chromosome 16 is involved in Crohn's disease. 16, 12, 6, 14, 5, 19, 1, and others may be involved in ulcerative colitis, but most common is 6. While in Crohn's disease, the 40x incidence when the allele variant of NOD2 gene on both chromosomes are present. This is genetics for the Crohn's. The site is almost always involved, the rectum. Remember, rectum should be involved in 95% of cases. Descending colon and sigmoid colon, other favorite sites. 95% of cases. Commonest in Crohn's disease is ileum. In 60% of cases, less than 50% is the colon and rectum. Rectum often is spared. Anal lesions are common, but the rectum is spared with anal lesions. This is very unique type of a disease. Rectum is spared, but there are perianal type of tag or perianal fissures. There are fistulas around the anal canal, but the rectum is normal. This is a very interesting situation. In the pathological examination, only the mucosa involved and some part of the submucosa. In Crohn's disease, all is involved. The mucosa, submucosa, and serosa. It is an enteritis. All areas are involved. Crypt abscesses are common. Inflammatory polyps, which are pseudopolyps, are seen in the microscopy, and in the what is called as the barium meal examination, pipe stem type of the colon is seen. In crypt abscesses are rare in Crohn's disease, and non-caseating giant cell granulomas present in 60% of cases. Now, this is the slide which is showing transmural colon involvement in Crohn's disease in front of you. Right? Transmural means that all layers are involved in Crohn's. This is a normal colon. In this diagram you see, in ulcerative colitis you see there are the crypts are formed inside and abscesses are there under the microscope. Clinical feature: the watery or the bloody diarrhea, rectal discharge with mucus, proctitis, and left-sided and total colitis is there. In ulcerative colitis, in Crohn's disease, there is a chronic diarrhea actually. It is a small bowel diarrhea, abdominal pain, food fear, weight loss, pyrexia, right iliac fossa pain. It may be mass, it may present as a mass in the right iliac fossa. And it mimics the appendicular mass. In certain cases, they open it. When they open it, they found it's something else. So acute intestinal obstruction can occur because of the transmural inflammation. And multiple perianal fissures and fistulas and abscesses are common consequences in Crohn's disease. These are the polyps which are seen in ulcerative colitis under the lower GI endoscopy. Now, toxic megacolon and fulminating colitis and perforation and severe hemorrhages are seen in those cases who are not treated properly. Severity is mild, moderate, and severe. But in Crohn's disease, the intraabdominal fistulas, it may be indirect, it may be intercutaneous. It is more surgical disease, Crohn's disease. Ulcerative colitis is more medical side disease. Now, in Crohn's disease, the complex anal fistula should be differentiated with the tuberculosis of the area, which also causes the fistula. This is a surgical actually problem. Surgeries, lot of surgeries are likely to be done in these cases. Now, this is the receptor which is called Th2 receptor in ulcerative colitis. When in Crohn's disease, Th17 receptors are found. In Crohn's disease, the fat wrapping creeping mesentery is also seen in laparoscopy. Now, extra chronic manifestations are seen in both cases. Remember, arthritis, skin disorder like erythema nodosum and pyoderma gangrenosum is more commonly seen in ulcerative colitis. In Crohn's disease, the peripheral arthritis, ankylosing spondylitis, sacroiliitis-like type of a thing, back pain, skin conditions like erythema nodosum and pyoderma gangrenosum are also seen in this Crohn's disease. It is the picture of the pyoderma gangrenosum. On the shin is seen. See, it is a gangrenous type of a lesion, and the borders are serrated, and the pus are coming out from it. Extraintestinal manifestations in eye disease, iritis, bile duct cancer, sclerosing cholangitis, hepatic disease occurs in stage-wise. Urological problem occurs in ulcerative colitis, nephrolithiasis because of the more absorption of the oxalates. In Crohn's disease, the eye disease, iritis is seen, bile duct cancers is seen because of the sclerosing cholangitis, which is seen in 0.4%. It's less common than ulcerative colitis, although it also happens in Crohn's disease. It is not very common. Hepatic disease is also seen in Crohn's disease, but not a very severe type of illness in comparative with the ulcerative colitis. Now, post-colectomy in the ulcerative colitis is the worst arthritis, pyoderma gangrenosum. But after the colectomy total, there is no change occurs in the primary sclerosing cholangitis and ankylosing spondylitis in ulcerative colitis, although it is benefited the arthritis and pyoderma gangrenosum. But as far as the musculoskeletal system is concerned, it is not beneficial. Arthritis in ulcerative colitis improves after colectomy. This is a very important point. And sacroiliitis and ankylosing spondylitis in ulcerative colitis, there is no change. Investigation, we do actually CBC and stool culture and pain film of the abdomen or the barium examinations, barium enema, lower bowel enema that is called. Sigmoidoscopy is the answer. Colonoscopy is the answer. Biopsy, histopathology. This will diagnose the condition. Crohn's disease, small bowel enema, barium enema, sigmoidoscopy, colonoscopy, again the biopsy. This will diagnose between the two conditions. Now in the sigmoidoscopy, the criteria is described. A colonoscopy, again the criteria is described, which we will discuss in the final year. In the Crohn's disease, the small bowel anemia and barium anemia will diagnose already. You can satisfy with the sigmoidoscopy and colonoscopy, and it is confirmed transpleural infection. If it's there, all the wall is involved, it is Crohn's disease. So this is normal endoscopic view. In ulcerative colitis, there you see how much colon is red, and there are white patches are seen, and it is protruding outwards. It is pseudopolyposis. In Crohn's disease, the whole area is red. From anterior to posterior, you see the absolutely red. Some parts are left. The anterior part is red. You go posteriorly in this diagram, the colon is normal. They are called skip lesions. This is the radiology double contrast medium enema study. Is showing the pseudopolyposis of the descending colon. In Crohn's disease, the skip areas and the regional iliatis is seen in this diagram in cases of the contrast barium enema, lower bowel enema. Strictures are visible in Crohn's disease in barium enema. In radiology, multiple strictures are seen in Crohn's disease in barium enema. Abscesses are more commonly seen in this condition. Again, I have said already, in cases of the Crohn's disease. So imaging is MRI is better than CT because the CT is better for the hard objects. MRI is better for the soft objects. You can go for the CT enteroclasis, go for the CT and do biopsy of the targeted lesion. Capsule endoscopy can be done. The endoscopic image of the ulcerative colitis already mentioned. I have, and the Crohn's disease, the skip areas are visible in this diagram. Now, very interesting thing, a very new thing which has happened in the last 10 years is that PNK, anti-neutrophil cytoplasmic antibody, are present more commonly in ulcerative colitis. But ASCA antibodies, that is the anti-Saccharomyces cerevisiae antibodies, are present in Crohn's disease. For example, somebody said that I don't want to do the biopsy, I don't want to go do the barium enema, I don't want to do the lower GI endoscopy. Then you can do these examination, which is if it is possible, and they are available. If they are available, now they are difficult to manage. The medical management of this condition is about the same. The first drug of choice is the sulfasalazine, and the active agent is 5-amino salicylates, 5-amino salicylic acids. They are the active ingredient which acts on the mucosa and submucosa. If it fails, then you go for the azathioprine, then immunosuppressions. If it also fails, you go for the steroids. topical as well as oral. And high fiber diet and the bulk forming agent as methylcellulose is given in ulcerative colitis. Sulfasalazine and amino agents which are available here in Pakistan very commonly, they are using in higher doses. If it does not work, then we go for the immunosuppression. And even if it is not suppressed, then we go for the steroids via oral, via rectal, via parenteral, whatever it is. And total parenteral nutrition is needed in these patients to rest the intestine. And metronidazole antibiotics have got role in this condition, but there is no role in ulcerative colitis because the bacteria which are present in the intestine already, which are called coliform bacteria, gram-positive bacteria, gram-negative bacteria, anaerobes are present. If you kill them, it will benefit these patients, that is of a Crohn's disease. So these are the drugs which are used, which are written in front of you. The thing is this, you go for the first drug of choice are the sulfasalazine or 5-aminosalicylates. If fails, you go immunosuppression and go for the steroids via oral, via parenteral, via rectal. If all fails, you go for the surgical and proctocolectomy plus permanent ileostomy. This is the answer to save from the carcinoma of the colon. Crohn's disease has got multiple surgery to do. 70% need surgery in any case for the fistulas, for the fissures. The complication of fulminant colitis and toxic dilatation of the colon and perforation of the colon and severe hemorrhage is commonly seen in ulcerative colitis. But in Crohn's disease, this is not seen. Other strictures are seen, lesions are seen, fissures are seen. The chances of the carcinoma of the colon in ulcerative colitis is more than in Crohn's disease. This is the Montreal classification of the ulcerative colitis. Mild, moderate, severe, depending on number of the stools, blood in the stool, abdominal pain, and systemic toxicity present or not, ESR, anemia, etc. I will discuss in the final year this Montreal classification of severity and how we will manage. And another classification for the Crohn's was defined as the Vienna classification. And this will be discussed again in the final year. It is not for you. So this is the difference between ulcerative colitis and the Crohn's disease. As the third year level is concerned, you should understand the difference, the basic difference between these two diseases, the presentation, the management-wise. The medical management is the same, but the surgical management is different in the two conditions. The chances of the carcinoma of the colon is more in ulcerative colitis. The chances of the carcinoma of the colon in Crohn's disease is less. So in cases of the ulcerative colitis, frequent endoscopy is needed. Remember this thing. 6 monthly. In case of the Crohn's disease, it is 1 yearly or 2 yearly endoscopy is needed. Not often. This is the difference between the two diseases. Although I think the lecture is very, very prolonged, our discussion is very prolonged, but I want to clear the diseases between the ulcerative colitis and the Crohn's disease, and the conception has given to you. I think you have understood these points. You can learn from your book also and try to remember. Inshallah, we will meet again sometime, someplace, or on the video conferencing. Assalamu alaikum.